artery, which you call the pericardophrenic or intercostals. Lymphatic, it's anterior and posterior mediastinals, and visceral, because it has a tracheal and bronchial lymphatic drainage. So as you can see, the boundaries of the pericardium, superiorly, it goes into the covers the aorta, SVC, and SVC above the SA node. Inferiorly, medially, and laterally, it's actually encompassed. It's just like it goes around the heart, in the back of the wall, around the pulmonary veins, IVC. And this is very important because you can still access the IVC from inside of the pericardium. And in the back, it's attached to the left atrial wall just before the arterioventricular groove. So what are the physiology of the pericardium? The fibrous and the brighter layer, it's very form of dense collagen fiber, and this is non-compliant, and this would help to keep equilibrium of the compliance of both ventricle. However, this is very important because it helps determine the diastolic pressure of both ventricle. We know that when we take a deep breath, the venous return will increase, but however, the pressure will decrease because there will be transmitted the pressure through the pericardium into the ventricle. Intra-pericardial pressure, is it always change with respiration? So the inspiration increase your RV filling. Why the inspiration increase your RV filling? Can somebody answer this, please?
Because increase the negativity of the in the thoracic.
So you increase, you become, your intrathoracic pressure become more negative. And what is the effect when you increase your venous return?
Increases the passive filling.
Increase the filling of the right ventricle. And this what cause when you increase the filling of the right ventricle?
Pushing its septum.
Exactly. The septum will push into the left ventricle and your pressure will go a little bit down. So because of the intraventricular septum will shift to the left, there will be increase in RV filling, decrease in LV filling, and this will decrease your blood pressure. However, the drop in the blood pressure, this is normal phenomenon, but should be less than 10 millimeter mercury. What if the blood pressure drop more than 10 millimeter mercury, guys?
This is
what do we call this phenomenon?
We call it pulsus paradoxus.
Okay, can you tell me what's pulsus paradoxus?
Increase in drop in blood pressure more than 10 millimeter with deep inspiration.
Excellent. So you can see that pulsus paradoxus, it's a drop in the blood pressure more than 10 millimeter between inspiration and expiration. And this happens due to tamponade or acute filling of the pericardial space. This is very important. So one of the disease in the pericardium is absence of the pericardium. Usually most commonly happens in the left side. It associated with absence of left cardinal vein. This is from the embryological origin. Right side less common, 13 to 17%, and this is due to defect in the right duct of the cavio. How we diagnose absence of the pericardium? The best modality is MRI. The consequences of the absence pericardium is hard displacement, entrapment of the LV and left atrial appendage. Usually we treat this with either we do complete pericardiectomy, or if there is a defect, you can actually put a pericardial patch just to prevent heart entrapment. Congenital pericardial disease, we have what you call a pericardial cyst. This is 70% accidental finding. Most commonly happens in the right costophrenic angle. It's smooth, 3 centimeter in size, uniloculated, does not communicate with the pericardium. If symptoms occur, which usually chest pain, short of breath, arrhythmias, cough, or compression to other structure, and sometimes can cause secondary infection, the best investigation is to do a contrast CT scan. The treatment, you can aspirate, but there is 1/3 of these cases they will come back with risk of recurrence. You can use a sclerotherapy when injected with the sclerotherapy, and this should fuse the cyst. And the only curative is the surgery. However, surgery is indicated only if it's large size or if the patient has symptoms, if you suspect malignancy, or if the patient requests to get it out. Acquired pericardial disease. Acquired pericardial disease, this has happened when there is accumulated fluid in the pericardial space. This is we call it tamponade. And the blood is the most common. However, sometimes fluid can happen if the patient have pus or oxidative fluid, like the patient have cancer. Tamponade will compress the low pressure chambers, which is including the right atrium and right ventricle, and this should impair the diastolic filling and drop your cardiac index. So what are the triad of tamponade? Let's make this interactive session. What is the triad of tamponade? Don't look at the slides, just answer.
Distended neck vein, muffled heart sound, and hypotension.
How do you compensate? Like if the patient is having tamponade, how is the patient trying to survive with tamponade?
Tachycardia. And increasing the preload.
Your preload cannot be increased because you already restricted, right? You have compression. You try to increase you're giving fluid because you want to try to increase your preload, but the most important thing, the patient will become vasoconstricted. Systemic vascular resistance will go very high. They will have tachycardia, as you said. You have to be careful when you're dealing with patients with tamponade, especially if you want to intubate the people, intubate these patients, because the moment you give them the sedation, they will lose their they lose their vascular tone, and they can crash like very fast. Because of that, sometimes what we do what you call it prep and drape. Prep and drape, then induct and intubate while you're ready, because if you drop the pressure, you will open up. How does the tamponade or present? If it's acute tamponade, you just need as less as 100 ml in the pericardium that can cause tamponade. However, in the chronic cases, when there is a time for the pericardium to stretch, sometimes the pericardium can take up to 1 liter. This is a graph which taken from Lawrence or Cohn book. This will show you the difference between the pericardial fluid when it happens in the rapid effusion or slow effusion. As you can see, in the rapid effusion, you can see that the pressure and the intrapericardial pressure will go very high, very fast, because as you can see the slope of the curve here. So it goes very rapid because there is the pericardium is still tight and there is no time for the pericardium to stretch. So the pressure will build up rapidly. However, if you have a very slow pericardial effusion, you can see that the pressure will grow up very slowly, and then we reach up to the point that the pericardium cannot be expanded anymore, and then your pressure will start to build up again. So, pericardial constriction. Pericardial constriction, it has an effect on the diastolic RV filling, which lead to decrease in the cardiac index and increase your systemic venous pressure. As you guys know, this is a very chronic problem and can present with symptoms of RV failure, which include fatigue, decrease in exercise tolerance, dyspnea, orthopnea, and RV failure symptoms, peripheral edema, ascites, and liver congestion. So, what are the major difference between tamponade and pericardial constriction? Can somebody comment?
In tamponade, there will be equalization of pressure in the full chamber, and in all the cycle. And constrictive pericarditis, there will be a fast filling pressure, but then plateau pressure on the late filling.
Yes, so the impaired in the RV filling and the tamponade, it happens throughout the cardiac cycle. This is a tamponade. In the constrictive pericarditis, the filling, it's only happen the filling problem is impaired in the diastole only, and it's mainly the late diastole. Okay. So the walls of the ventricle is immobile because, and the septum is only the one that moves. This is very important because, you know, the heart in very confined space, and the wall of the ventricle cannot be actually like stretched. So the only mobile part of the heart is the septum. That's why we call it, what you call it, a bounce back septums. What are the other echo findings that you can see? You can see a thickened pericardium, caval enlargement, and small cardiac chambers. And this is very important because when you talk about how we're going to differentiate between constriction and restrictive cardiomyopathy, we will talk about this. What are other modalities of diagnosis? You can use CT, MRI to visualize the thickened pericardium. Sometimes you can see some calcifications. Cardiac cath, it's the important diagnostic tool. It used to be, and still the gold standard. And we will, in the next slide, we will show you what's square root signs. Pericardial constriction is associated with an important finding, which is called a cosmal signs. What is, anybody knows what's cosmal sign?
Decrease in blood. Decrease in
but,
blood pressure more than 10 with reversal of decrease of blood pressure with deep inspiration.
So what happened when you, in normal people, what happened when you take a deep?
In normal people, when you take deep breath, the central venous pressure will drop, decrease.
Exactly. So the GVP will go down.
Yes.
So what happened in cosmal sign? When you take a deep breath, the GVP
deep
will
breath,
go up.
they go up, yes.
So that's what happened. This is what we call cosmal sign. So pulsus paradoxus, it is more with tamponade.
Okay.
It's more with tamponade. Cosmal signs is more with constriction, right?
Yes.
Yes.
This also a graph taken from Cohn or from Lawrence. So as your friend comment about the RV filling, you can see here, you can see the difference between tracing of the LV and RV. This is the LVs, right? This is the LV, the big one, right?
Yes.
You see? And this is the RV, right? So as you can see, the RV will have a very rapid filling, as your friend said, and then you have the plateau. And this is what you call it a square root sign. So, and this is why this happens, because the filling will happen very rapid because the heart is constricted. So there will be a lot of gush of the blood goes initially, and then because there is a restriction, because there is constriction, the ventricular wall cannot expand. So then you will have the plateauing of the pressure, and this is what we call a square root sign. So cardiac cath is important to differentiate between cardiomyopathy and restrictive cardiomyopathy, because this is the question always. How are we going to differentiate? And this is very important exam questions, either in written or it's in the oral exam. If they present you a case which is suggestive of the patient have a constriction, then they will ask you how we really would differentiate between restriction or restrictive cardiomyopathy. First of all, you need to know from the history if there is any thing can lead to a restrictive cardiomyopathy, like the patient have history of amyloidosis, sarcoidosis, it's a cardiac tumor, the patient have history of radiation, or patient use anthracycline toxicity. You need to know that restrictive cardiomyopathy, this is not a surgical disease, because it's a myocardial issues. Constrictive pericarditis and restrictive cardiomyopathy, sometimes both you can have normal ejection fraction. However, patient will have an RV failure. Patient with restrictive cardiomyopathy, they usually have an RV failure because of the impairment of the myocardium of the right ventricle. However, in their constrictive pericarditis, the RV usually normal. Pericardial thickness more than 2 centimeters is not enough. So you say pericardium is thickened more than 2 centimeters. This is not enough that you say this is constrictive pericarditis versus over restricted cardiomyopathy. And also radiation can cause both, because radiation can cause the pericardium to be thickened, and it can cause a restriction cardiomyopathy in the myocardium. cardiac myopsy is a very good tool to look into restrictive cardiomyopathy. However, if you have a biopsy and the biopsy tell you that it's negative, you still cannot rule it out. This is a very important table. It's also taken from Kohn. So there is 3. If I am an examiner, I'm going to ask you a question. I'm expecting from you to answer me. Said, okay, sir, we have 3 things. I have a physical exam, I have a hemodynamic data, and have echocardiographic data. It can tell me that how I'm going to differentiate between pericardial constriction and restrictive cardiomyopathy. So if the patient have a pericardial constriction, he might have a pulsus paradoxus. It's variable. However, if the patient have restrictive cardiomyopathy, you will never see a patient have a pulsus paradoxus. Pericardial knock, or what you see, like you see that like you hear abnormal voice in the pericardium. This is a feature of pericardial constriction, and presence of S3, which is a gallop. This is also it's a heart sound, which is feature of heart failure, and this is present usually in patients with restrictive cardiomyopathy. Now, in terms of hemodynamics, you guys know the GVB waves, right? So usually in GVB wave with wide descent, it will be prominent. This is usually signs of a pericardial constriction, and this might be present, but it's very variable. This is very important here now. If patient have equalization of the right and left-sided filling pressure, this is in favor of pericardial constriction. However, in patient with restrictive cardiomyopathy, usually the left side pressure is more than the right side pressure. Now, this is very important again. You have to look into RV in diastolic pressure and ratio it to the systolic pressure. If the patient have a right diastolic pressure in ratio to the systolic pressure more than 1/3 in diastolic pressure, this is in favor of constrictive pericardial constriction. However, if the pressure is lower than 1/3, this goes more with restrictive cardiomyopathy. Pulmonary hypertension usually does not present with the constriction, but usually it's a common feature of restrictive cardiomyopathy. And square root sign, as we said, it's the pathognomonic for the pericardial constriction. Now, in the echocardiography, what you can see to tell you that the patient have a pericardial constriction, there will be a respiratory variation in the right and left pressures flows. This will increase because, as we discussed this before, right? Because the only moving part is the septum, so the RV cannot stretch. So there will be what you call bounce back septum. So when you take breath, there will be venous return going to the RV. The septum will go to the left. There will be increase flow on the left, increase on the right, and this will be very prominent in the pericardial constriction. However, it will be normal in restrictive cardiomyopathy. Septal bounce, as I said, present with pericardial constriction. Look here, atrial enlargement, it's variable, but usually in constrictive in pericardial constriction, you don't see enlarged atria. However, in restrictive cardiomyopathy, you see biatrial enlargement. Ventricular hypertrophy, you don't see ventricular hypertrophy with pericardial constriction, but usually present with restrictive cardiomyopathy because it is kind of amyloidosis sarcoidosis, which is affecting the muscle and making the muscle thickened. And pericardial thickness usually present with pericardial constriction, but as I said, it's not a clear-cut sign. So this is a very important thing. This is another table, but this is okay. How we really differentiate between restrictive cardiomyopathy and constrictive pericarditis. So, as I said, in restrictive cardiomyopathy, RV and LV pressure, it's concordance with the respiratory cycle. What's mean concordance? That means will have the similar as the normal people. When you take a deep breath, your RV pressure will increase, your LV pressure will go down. And this is what you call ventricular dependence. However, in constrictive pericarditis, RV and LV pressure discordance with the respiratory cycle. And I will show you in the next slide what does this mean. and this is, we call it ventricular interdependence. This is another important phenomenon, because you have to keep in mind that when we talk about pericardial disease, you need to talk about square root sign, and you need to talk about ventricular interdependence. And restrictive cardiomyopathy, no square root signs, and constrictive pericarditis, square root signs. And restrictive cardiomyopathy, no ventricular interdependence, and constrictive cardiomyopathy, there is ventricular interdependence. LV in diastolic pressure higher than the RV, but here RV and LV in diastolic pressure elevated and equal, as we said in the previous. Usually with restrictive cardiomyopathy, the patient comes with heart failure, so they will have high BNP level. However, with constrictive pericarditis, this is not a heart failure; it's a filling problem, so people will have a normal BNP. So I want you to see, guys. So as you can see here in A and B, okay, guys?
Yes.
See now, let's talk about normal first, okay? So normal, patient's taking a breath, right? So he's at the end of the expiration, right? You see that the pressure will goes down, right? But will not go down more than 10 millimeter, right? We said this is what we said in the left.
Yes.
Because the RV pressure initially will go up, but it eventually will start to go down because of the filling. However, look here, when the patient have constrictive pericarditis, the pressure is 120, right? Look how it does drop to like 90. So drop in 30 millimeter mercury, and this will grow up. You see, this goes down, this goes down, this goes up, and this goes down. Did you get it?
Discordance.
This is what you call it ventricular interdependence. What's ventricular interdependence means? That means when I take a deep breath, the RV pressure will grow up, so the septum will push into the left ventricle, so the LV pressure significantly drop because there is no volume, there is no room for the ventricle to expand, right?
Yes.
But in normal people, you're still gonna increase your RV pressure, but the RV pressure will goes down, though you're increasing your volume, and the LV pressure will also goes. So this both ventricle goes in the same direction. This we call it ventricular concordance. This we call it ventricular inconcordance. Is it clear?
Yes.
This is very important because again, if I am an examiner, I might brought this for you and explain for me what does this mean, and what is the ventricular interdependence, what's ventricular concordance, and what's the square root sign. Now we'll talk about constrictive pericarditis, or it's the most common pericardial disorder. We have a lot of etiologies, including infection, inflammation, radiation, metabolic, post-cardiotomy, neoplastic, trauma. Most common presentation is dull aching chest pain. Patient sometimes can present with the chest tightness with constitutional symptoms, including weakness and malaise, fever. Sometimes patient can present with cough and adenophagia. How we investigate patients with with acute pericarditis. I'm talking about acute pericarditis. EKG non-specific. Sometimes you can see diffuse ST elevation and PR segment depression. Chest X-ray most likely normal, and echo may show the fibrous thickening, but with or without pericardial effusion. How we treat acute pericarditis? We treat it with non-steroidal anti-inflammatory drugs, colchicine. Sometimes in severe cases you can give steroids. What are the complications of acute pericarditis? Patient can go into constrictive pericarditis, and patient can have a chronic pericardial effusion. So this is a table. Also, it's taken from Cones. You can go over it like on your own, but you need to know what are because they might ask you about what are as an exam question. Give me different causes of acute pericarditis. So you'll say infectious, autoimmune, vasculitis, metabolic disorders, disease of contagious or structures, neoplastic, trauma, uncertain etiology, and pathogenesis. So you can go over this. So very important thing they also might ask you about because you guys know TB in Saudi is still very common in certain areas, and also in Asia, and some certain Asia. So sometimes when the people get a TB pericarditis, there is 4 important stages that you need to know, because they might ask you what are the stages and what are the features of these stages. So stage 1, this is when we call it exudative pericardial effusion. And if you take a sample from the pericardial fluid, you might actually able to grow mucobacteria. Stage 2, this will go from exudative to serous and serosanguinous effusion. And here, when we form what you call a foam cells. Foam cells will go into giant cells or will develop cheeses granuloma. And finally, you will have a very bad fibrosis and calcification of the pericardium. So post-infectious pericarditis, it may make ischemic pain and cause unnecessarily revascularization, can cause adhesion, make the operation difficult, and obscure epicardial vessels. Post-pericardectomy syndrome, this is very common, you know, like after cardiac surgery. You could see it a lot in ICU. Oh, the nurses will jump to you. Oh, sir, doctor, there's a patient with a ST elevation. You come, you did for this guy 3 grafts, beautiful. The patient is hemodynamically stable. So you look at the EKG and you find there is a diffuse ST elevations everywhere. Usually patient is presented like which develop what you call Dressler syndrome. The patient have a white count, fever, and ST elevation. Usually we treat this with non-steroidal anti-inflammatory drugs such as naproxen, and in refractory cases, again, we could use steroids. Post-op tamponade, this is very important. It's circumferential fluid collection, or sometimes it's localized into the right side. You need to know about the late cardiac tamponade. Late cardiac tamponade usually happens up to 3 weeks, and it's a series of the cardiac surgery show that happens from 0.5 to 6%. Usually presented as the symptoms of decreased exercise intolerance, shortness of breath, decreased urine output, and hypotension. You diagnose with echo, and you could do pericardiotenthesis. Sometimes pericardial closure, people, you can read it in the book, it's considered as one of the pericardial problem, like pericardial disease. It's not a disease, but some people like to close the pericardium to keep a layer between the heart and the bone. Disadvantages include you can kink a graft if you're doing a cabbage. Operation for pericardial disorders, mediastinal re-exploration. Post-op cardiac bleeding happen 35%. The presentation usually decrease chest tube output, increase CVB, low cardiac output, low urine output, acidosis, and increase process requirement. If you see this kind, if you're on call and you see this in ICU, that's a very high suggestive that the patient have post-operative bleeding. So echo finding usually find RV and RA diastolic collapse. With inspiration, there will be increase in the RV in diastolic diameter. Inspiration will decrease the LV volume. It looks like exactly. This is very important because they might ask you in the exam, give me the echocardiographic criteria for the tamponade. So you have to mention these 4 points: RA, RV diastolic prolapse, inspiratory increase in RV in diastolic diameter, inspiratory decrease in LV volume, increase in tricuspid valve flow velocity, and decrease in mitral flow velocity. How we treat post-operative bleeding: you have to correct the coagulopathy, correct the acidosis, hypothermia, and hypovolemia. You can give blood product. If the patient acute crashed in the ICU, sometimes you have to open him in ICU. And the definitive treatment, you have to take the patient back to the operating room, check all your suture line. Pericardiotenthesis can be done with aid of fluoro, echo, CT. We need a monitor like EKG and Artline. Does anybody did a pericardiotenthesis before?
Yeah, I did once.
Can you explain to us how you do it, please?
There is two ways to do it. From you sterilize the area you will go in. You prepare your instrument and the catheter, and you go with the needle either from subxiphoid or from the 5th intercostal space anterior axillary line with help of ultrasound. And you go with negative pressure till you see blood, and you see your needle in the cavity, and you watch the monitor for any arrhythmia, because if you induce arrhythmia, that most likely your needle touching the heart. Then you introduce the guide wire and the catheter over the guide wire in Seldinger technique, and you fix the catheter if you want to keep it, or aspirate and take it out.
Okay, that's
Also
okay.
from
So
subxiphoid area, Hussein, I think it's better than the fifth intercostal space, because the echo you can bring the apical four-chamber view and go towards the left yani your needle direction going towards the left shoulder. You did it from subxiphoid, or you did it from fifth?
Subxiphoid.
Subxiphoid,
But
yeah, the book
I saw
mentioned.
it many times, and the surgeon usually in our center, they did it from the fifth intercostal, but the interventionist and cardiologist from the subxiphoid.
okay.
So what do you think, Dr. Mohammed?
I recommend don't go to fifth intercostal space, because you're very close to the heart when you go to the fifth intercostal space.
Yes.
I would recommend if you go to how it's already prescribed, that you have to go to the subxiphoid area. As you say, you aim to the left axillary. You use the needle under echocardiographhic guidance till you see your needle under negative pressure. Sometimes what the people use, they use a catheter with electrode. Yes, electrical probe. Yeah, then they can actually look into if they are touching the heart. So pericardial window, it's a limited resection of the pericardium and drain the fluid to pleural or peritoneal spaces. There is three main approach: thoracoscopic, anterior thoracotomy, or subxiphoid. So thoracoscopic is very simple. You go with this is done mainly by our thoracic colleagues. They put the patient left side up. They do like a triangular orientation of their instruments. They go, they drop the lungs, they identify the pericardium, and then they resect the pericardium on top of the phrenic. You have to watch the phrenic so it does not cause the phragmatic paralysis. Anterior thoracotomy, this is you do it in the fifth intercostal space, anterior toward the sternum. You're also going to have a direct approach to the pericardium. You also have to be careful when you do this. You have to watch for the phrenic nerve also. Subxiphoid, you make a 5 centimeter incision below your xiphoid. Then you go there and you retract the subxiphoid area with rakes. Then you open the pericardial space and you resect as much as you can see from the diaphragmatic pericardium. And some people, they connect the pericardial space with the peritoneum space, so they can the pericardial fluid can be drained into the abdomen. Pericardiectomy, it's the only treatment for chronic constrictive pericarditis. The very important thing you have to keep in mind when you do pericardiectomy, it's the issue of calcification that can penetrate into myocardium, and this sometimes can make the resection difficult and challenging. So, okay, can somebody tell me what are the operative steps for pericardiectomy? How we do pericardiectomy?
So usually.
So just a second, how many chief resident or R7 we have in the panel?
Okay, we have me, Hussein, the one, Hussein Gattan, he's from university, the one who was also speaking. We have also Bayan from Jeddah, Faisal Hamadi, and Uthman al-Milham. 5, we are 5.
Okay, so let's alternate the answers between you guys, طيب? So you can answer these questions, or you want somebody else to answer the question?
I can go ahead. Discuss pericardiectomy.
Okay,
please go ahead.
Faisal Hamadi from King Faisal Specialist Hospital.
Faisal, please, how you do the pericardiectomy?
So what I've seen is usually done through a median stenotomy, and once the pericardium is done with sufficient dissection, we do it from phrenic to phrenic. on
Okay.
the lateral limits are phrenic to phrenic. The superior and inferior limits, I cannot recall them now at the top of my head, but I remember the phrenic to phrenic rule.
Okay. So, as you say, we do median sternotomy. I always keep my pump ready. Sometimes sometimes the pericardium is very adherent to the myocardium, and you may need to prefer cannulate. So people like to do these operations on beating heart because they would like to have some contraction by keeping the heart full, right, distended.
Yes.
Some people, they also do it from the left side via left thoracotomy. Yes, you said the most common approach is median sternotomy, but some people have done it through the left thoracotomy. As you said, the idea is aim to full anterior pericardectomy from phrenic to phrenic. Some people also resect posterior to the pericardium, especially at the IVC area, because these people, they come with you with very bad lower limb edema and RV congestion, right? Sometimes the IVC itself is constricted. So some people will cut the pericardium all the way down to the IVC, make the IVC free. And also the pulmonary vein. طبعا, you need to keep an eye on, about the risk of bleeding, tearing of the heart, and injury of the coronary vessels. Initial series showed a very high mortality rate, but however, with development and with the new series, the mortality rate dropped from 10 to 20% up to 5%, which is almost a quarter. And the survival dropped with if the patient have a post-operative radiation pericardectomy because the patient have previous radiation exposure, their survival dropped. This is very clear. You can see here. If the patient have idiopathic pericarditis, they have a very good survival. If the patient post-surgical, their survival, it's better than the radiation. However, the post-radiation, this is the carries the worst post-operative survival. And radiation can affect a lot of things. Can cause restrictive cardiomyopathy, as I said before, can affect the myocardium, can affect the valves, and also can affect the ostial of coronary artery disease. This about pericarditis or the pericardial disease. Any questions before we move forward?
From my side, thank you. But the others, any question?
Thank you.
Thank you.
Okay, so just keep in mind how you differentiate between restrictive cardiomyopathy, constrictive pericarditis, ventricular interdependence or ventricular concordance, and square root sign. If you get out of this lecture and you understand these three concepts, that's amazing. Okay, now we'll move the gear to cardiac neoplasia. This is also another big topic, but we'll try to make it as well short and sweet. So 10 to 20% of patients dying of dismantled cancer that metastasized to the heart. The incidence of the good thing about primary cardiac tumor, it's very rare. It's like 0.17 to 0.29 in unselected autopsy series. The good thing that also 75% of the cardiac tumor are benign, 25% are malignant, and 50% of these benign tumors are myxoma. And 75% of the malignant tumors are sarcomas. Sometimes we find that some ectopic thyroid tissue more occur within the myocardium, and this is what you call it at the stromal cordis. So this also was taken from Kohn or Lawrence. This table will show you the different types of cardiac tumor by its pathology. So you can tell here that there is something called a pseudo tumor, or what you call it, that's due to moral thrombi. Okay, or you can have a heteroblast and tumor of ectopic tissues, as we said before, ectopic thyroid, or tumors of the atrioventricular nodal region, or teratomas. Tumors coming from mesenchymal tissues such as hamartomas, endocardial tissue, papillary fibroelastomas, hamartoma of cardiac muscles, rhabdomyomas, histocytoid cardiomyopathy, or tumors coming from the fat like lipomas hypertrophy, intraatrial septum lipomas hypertrophy, lipoma or liposarcoma, You can go through the list. Any cardiac tissue present in the heart can present with a tumor. This is a very important table, because they might ask you in the exam, please give us the most common, 4 common benign cardiac neoplasia. So what are the most common benign cardiac neoplasia? It's myxoma, number 1, followed by lipoma, followed by papillary elastoma, followed by hemangioma. This is where? This is an adult. What about pediatrics? Or children's? It's a little bit different. So the most common is rhabdomyoma, followed by teratoma, followed by fibroma, followed by hemangioma. This is a very important, and you need to memorize for your exam. Now, we said 50% of the benign tumors are myxoma, so we need to spend some time in myxoma. So myxoma comprise of 50% of all benign cardiac tumor in adults and 15% in children. The DNA genotype, it's usually sporadic, and 80%, that means it's non-familial. But myxoma of sporadic, it's associated with low recurrence rate. However, 5% of myxoma patients show a familial pattern that can develop due to autosomal dominant inheritance. All familial, and the 20% of those with sporadic myxoma, they have a DNA genotype chromosomal pattern. And usually these patients are young, they have multicentric and high recurrence rate. You need to know about something called a Carney's complex. Carney's complex, this is due to protein kinase A regulatory subunit 1 alpha, which we call it CARA1, and other genes involved. This is an autosomal X-linked inheritance. Usually people presented with the primary with pigmented nodular adenocortical disease, and due to that they present with hypercholesterolism. They become with cutaneous pigmentous lentigus, and they present with cardiac myxoma. So cardiac myxoma, it's a part of the Carney's complex. So what are the pathology? It's atrial myxoma generally arise from the intra-atrial septum at the border of the fossa ovalis, but can originate anywhere within the atrium, including the appendage. Myxoma are round or oval, smooth, lobulated, polypoid, compact, pedunculated, mobile, and not likely to fragment it spontaneously. Histologically, it's very important. It's composed of polygonal shaped cells and capillary channels within an acid micropolysaccharide matrix. The base of the tumor contains usually arteries and veins that connect to the subendocardium. There is occasional presence of the hematobiotic tissues and bone in these tumors. Myxoma can develop after cardiac trauma, such as patients going for ESD or patient went for transseptal puncture. Sometimes at that area, myxoma can happen. How does these people present? Can anybody tell me how these people present? First of all, when you talk, please introduce yourself so I know.
Okay, the presentation.
Haytham?
Haytham, yes, sorry. So the presentation depends on the size and the location of the myxoma to start with. Usually we have constitutional symptoms that can manifest in all patients, which is like fever, malaise, fatigue, and if the myxoma is big or causing any obstruction, they will present with obstructive symptoms mainly, and that can lead to heart failure symptoms if they presenting with obstruction. If they present high, it can also lead to right heart failure or left heart failure, depend on where the obstruction is. And this is how I categorize the myxoma in my mind.
So it can cause intramyocardial obstruction, can cause a congestive heart failure. This is the most common, 67%. The most important thing, Haytham, they can present with embolization. As you remember, you remember the lady we did together?
Yes, yes.
They present with a stroke. Symptoms or constitutional symptoms, as you said, fever, weight loss, fatigue, malaise, weakness, arthalgia. Why these people have constitutional symptoms? Because the tumor itself, they produce interleukin-6, and sometimes there will be tumor antibody complex that can activate the complement system. That's why the patient presented with constitutional symptoms. It can present with cardiac rhythm disturbances. Sometimes this tumor also can get infected. So diagnosis. Okay, can somebody tell me what are the echocardiographic criteria for myxoma?
Okay, myxoma usually.
Just say, just a second. Another participant, please.
Can I? تفضل عثمان.
Echo characteristics of myxoma is usually arising from the septum and located in the left atrium. It will be polypoid, smooth surface, and with multiple echogenicity in the mass. Sometimes it can prolapse and obstruct also the nearby valve, which mostly is the mitral valve.
Okay, so diagnosis can be done with the as we said, the echocardiography is the gold standard. As we described, it's a globular, mobile, smooth, surface irregular, friable surfaces with multilobular appearance, 4 to 8 centimeter in size, heterogeneous. The most important thing, it's heterogeneous echogenicity with areas of the occlusence and sometimes calcifications. You can see another thing, such as when you listen to the heart, you could hear what you call the tumor blob. Sometimes this can be confused with the S3. If the patient have a right atrial myxoma, sometimes you can have what you call Canon A waves or large A waves because of the obstruction of the tricuspid valve. Chest X-ray, sometimes you can see calcification in the left atrium. ECG is non-specific, but you can see sometimes cardiomegaly, apparent ventral branch lock, or axis deviation. CT and MRI are useful in detecting intracardiac and pericardial extension. Is it necessary to get CT and MRI in all myxoma patients?
No.
No, only if there is suspicion of malignancy or tissue characterization.
Well, I think it's not necessary, yes, but I think in your exam, I would recommend that you get, say, if the patient is stable, you said I would like to get a CT scan just to make sure we don't have an extra cardiac extension. Nobody will fail you for this, and I think you will. This way you play it more safe. So let me see if this video will work. I hope. Unfortunately, it does not work. So as you can see here, this is a big mass. It's in the left atrium attached to the intraatrial septum, and sometimes this goes to the occlude and the mitral valve. And here, as you can see, the echogenicity. There is different echogenicity in the mass. This is another left atrial myxoma, but this is not attached to the intraatrial septum. It's attached actually to the left atrial wall, and you can see here different echogenicity. This is another intraatrial myxoma, but this is actually in the right side of the heart, and you can see it's protrude through the tricuspid valve. So, can somebody tell me how we operate in myxoma?
Can I go for that?
What's your name, please?
I'm Hussein Gattan.
Fadal Hussein, please.
We go most approach sternotomy and sternotomy hibernization and bicaval cannulation, unless if you have concern or the myxoma on the right side and you want to be more careful not to injure or cause embolization of the myxoma on the right side. Better to avoid vent in this patient. You vent from the aortic route. Then you have two options. You can do it from the right side or by atrial approach. From the right side, you can see, when you open the right side, you can see the base of the myxoma attached to the septum. You make incision with elephant blade, then you complete your resection under fission and close the defect, and you examine, of course, the right atrium, left atrium for any other lesion, and you close the defect with batch.
Okay. Haytham, can you comment
Okay.
how we did it together?
So same bicaval cannulation, then snaring, then opening. Actually, by atrial approach, we went through the left atrium. We saw the myxoma. After that, we open also the right atrium to be sure about the margin. Then, of course, in these cases, we have to be with what's they call it, minimal handling. While doing this, because we don't want to end up with embolization. Then carefully resecting the myxoma, and after that closure of the ASD that we create. And the most important thing, we have to have a very good margin, because that will eliminate the recurrence of the myxoma. And we close the left atrium, then the left ventricle. The left atrium and right atrium after we finish.
So my advice to you guys, always do biatrial approach, because I have seen it before. The surgeon was cutting and he cut all the way to the mitral valve, and we have to end up with repairing the mitral valve as well. So sometimes on the right side, sometimes on the right side you cannot really see the total attachment of the atrial myxoma. So open the left atrium, open the right atrium, look from the left side, make sure you're not touching any vital structure inside the heart, and then you complete your resection. So biatrial approach, full thickness as we said, margin negative, excision at the side of the attachment, and patchy closure, or sometimes if the defect is small, you can close it with the primary closure. Operative mortality is 5%. As I say, recurrence for non-familial is 1 to 4%. However, if the patient have familial or DNA problems, the recurrence rate of 12 to 40%. This from the Cohn's book, but he did all the surgery from the left side, and then he also repaired the intra-atrial septum from the left side. Okay, so we're gonna go quickly scream over the different type of tumors, which is benign tumors.
Question, Dr. Mohammed.
Further.
Regarding the picture you've shown us, the myxoma rising from the left atrial wall, how do you manage this?
Okay, that's a good question. Look, the idea is to resect the mass, right?
Yes.
So it's the same thing. You have to resect the area, the mass from the left atrial wall, and then you repair the left atrial wall with a batch, like you do it like a batch, you know, like you take a circular resection, you get a circular batch with the bovine pericardium, and you suture it from inside of the left atrium. It's the same concept.
So the same principle as it's.
Yes, sometimes it's tricky. We're lucky because most of the time it's coming from the intra-atrial septum, which make actually the operation like you're doing an ESD. But sometimes when it's coming from left atrial wall close to the pulmonary veins, here you have to do more reconstruction. You know, sometimes you have to resect part of left atrium close to the pulmonary vein. You have to reconstruct and you have to reconnect the pulmonary veins. But I don't think we will talk about this more in detail when we treat a malignant tumor. But in intra-atrial myxoma, they make it simple: resect and batch. Whatever it's in the left atrial wall, right atrial wall, it's in the atrial septum. It's the same concept. Okay. So lipoma, well-encapsulated tumor may occur in anywhere in the pericardium, subendocardium, subepicardium, atrial septum. Please, 1 second. Well-encapsulated tumor, it's slowly growing. Subepicardial and parietal lipomas tend to compress the heart and may associate it with the pericardial effusion. Subendocardial tumor may produce a chamber obstruction. No recurrence after excision. Lipomatous hypertrophy for the intra-atrial septum. It's non-encapsulated in elderly female. MRI's diagnosis. Arrhythmias and heart block are an indication for resection. Papillary fibrillostoma. This is one of the most common tumors happens in the adult. It arises from any cardiac valve adjacent to the endocardium. Most common valve affected is aortic, followed by mitral, followed by tricuspid, followed by pulmonic. It can cause MRI or stroke because of embolization. Some series show that it's associated with the CMV. Resection, when diagnosed histologically, you can see a papillary band of a vascular collagen and elastin with mucopolysaccharides covered by endothelial cells. Recurrence rate in some series show that it's 4.3%.
Kindly, Dr. Mohammed, the
Yes.
indication for fibroelastoma, if it is asymptomatic and no embolization, do I have to intervene or follow up the patient? Because when I read, there is two opinion about this.
I think it depends on the presentation for the patient. If it's an accidental finding, the patient is totally asymptomatic, and there is it looks like a very small and it's attached to the aortic valve. You don't really need to do anything. But if the patient if he presented with any kind of embolic and then they found there is maybe a mass in the aortic valve, then this has to come out.
Okay, thank you.
So this is an echo which showed fibroelastoma, but this is not on it's in the tricuspid valve. And this is another fibroelastoma, but in the aortic valve. And when it's in the aortic valve, the most common approach is like you're doing an aortic valve replacement. You do aortotomy, you go and you look at the mass, you shave it and resect it and try to maintain the valve integrity. But sometimes if you damage the valve, you have to do an aortic valve replacement. Rhabdomyoma, this is most common in children. It is associated with tuberous sclerosis. That's why the patient presented with seizure, mental retardation, sebaceous cysts, and rhabdomyomas. It affects the ventricle more than the atrium. It causes valvular and subvalvular stenosis and arrhythmias. Symptomatic patients often have multiple and extensive disease. Usually, rhabdomyoma, we don't operate on them because the patient have this tuberous sclerosis and their prognosis is dismal. Fibroma, the second most common in children. It's a fibrous, non-capsulated, firm, nodular gray with tumor that can become bulky. Histologically, it's composed of broad spiral band mixed with collagen and elastin. Calcium disposition cause arrhythmias and chamber obstruction. Sudden death can happen in 25%. It can be, if it's local disease, it can be resected. However, if it's extensive and involving more than 50% of the ventricle, sometimes it's very difficult. You have to do transplantation. As you can see here, it's involving most of the ventricle here. So sometimes doing surgery to primary repair, it's sometimes difficult. Mesothelioma of AV node, it's a polycystic tumor, Purkinje tumors, or conduction tumors, sometimes we call it. People are presented here with heart block or ventricular fibrillation. ICD does not prevent fibrillation. The only, some people, surgical excision was reported before. Phenochronocytoma, this is another very important tumors. It's highly vascular. It's sometimes you have to do auto-transplantation because usually located in the posterior of the pericardium or posterior mediastinum. Cardiac phenochronocytoma arise from Kaufman cells of the sympathetic nervous chain and produce excessive amount of catecholamines and particularly norepinephrine. The patient usually presents with symptoms of uncontrolled hypertension, like any phenochronocytoma. And you do urine catecholamines, you find urine catecholamines is high. You can locate the tumor using a cystoscopy, which is iodine 131, or using meta-iodozolgalidine and CT MRI. Cardiac catheterization with the differential blood chamber sampling sometimes is necessarily in addition to the coronary angiography. Paragangliomas, this is another high vascular tumor. This tumor sometimes also required autotransplantation. It's endocrine tumor, can secrete catecholamine, most common located in the posterior mediastinum. As you can see here, this is a very high vascular tumor, phenochronocytoma, and in the second picture, a paraganglioma. Hemangioma, it's a benign vascular tumor with a variant presented with arrhythmias, shortness of breath, occur in any age. It's difficult to diagnose. Teratomas, 80% are benign. It's common in children. This comes like germ cell tumors or yolk sac. Castamen tumor, you need to know about this because I was asked about it before actually. It's poorly understood lymphoproliferative disorder. It's presented as solitary lesion in the mediastinum. Most common histological type are hyaline vascular, which account for approximately 90% of the cases and often behave as benign fashion. The more aggressive one, which you call the plasma or mixed type, and have a malignant behavior. Type of tumor present with the lymph node in the mediastinum with well circumscribed mass and myocardial and coronary artery invasion or development of coronary pseudoaneurysm. Complete surgical resection is the curative. This is how you can see how it looks like teratomas. Malignant tumors, 70% are sarcomas. What are the most common? They will ask you in the exam. So the most common one is angiosarcoma, followed by rhabdomyosarcoma, followed by malignant mesotheliomas, followed by fibrosarcomas. I'm sorry, I'm going a little bit fast because it's big talk. So primary malignant cardiac, you have to understand this in adults. So angiosarcoma, rhabdomyosarcoma, mesothelioma, and fibrosarcoma. And what are the most common presentation? They presented with dyspnea, the most common presentation, followed by chest pain, congestive heart failure, palpitation, fever, and malaise. We have to differentiate between right and left sarcoma. Right sarcoma metastasizes early. It's a bulky mass. It's infiltrative, and heart failure can happen in late stage. We have time to give a chemotherapy because the right side of the heart can distend a little bit, and the patient can tolerate not to have surgery early. We have to do surgical resection, and we have to reconstruct using a bovine pericardium. Left sarcomas, it's less infiltrative and metastasizes late. However, it grows in the wall of the left atrium and causes obstruction. Usually in the left side, we don't have much time for chemotherapy. That's why we need to operate in these people more urgently than right. And these are the people when we do what you call auto-transplantation. With cardiac transplant, still the median survival rate is only 12 months. This is what we said, right sarcomas. This is it's most common angiosarcomas. The most common angiosarcomas happen in the right sarcomas, occur in the right atrium, but can involve anywhere, RVT, tricuspid valve, or right coronary arteries. As I said, these we have time to do new adjuvant chemo followed by resection, but you have to cannulate the SVC and IVC. But sometimes the tumor goes down into the IVC, so you cannot really cannulate the IVC. So you have to do a femoral cannulation, so you can have a better control in the IVC. Left sarcomas, this is most common at the left atrium. 90% at the left atrium, and 80% happens in the left ventricle. Most common presentation is presented with obstruction or heart failure. Echo, CT, MRI, and PET scan. Survival is also dismal. At 1 year, it's 20% with surgery. Without surgery, drop to 10%. This is as you can see here, how is the angiosarcoma presented on the right side of the heart. It's involving the chest wall, and here it's inside, like you see, the right atrium, and the mass it's inside the right atrium. So sometimes you can have a right atrium myxoma, and also this myxoma is involving part of the left atrium as well. So as you can see here, this is also taken from Lawrence Cohn's book. We deattach the SVC, we deattach the aorta, we deattach the right pulmonary artery. You see there is a defect back on the left atrium, which was patched, and then we reattach the pulmonary vein from the right. Then we did the right PA. Then we have a bovine or like pericardium to reconstruct the SVC, and then we reconstruct the aorta with graft. So if it's involving the left atrium, this is what you call to do an auto-transplantation. Auto-transplantation means you cut the SVC, you cut the IVC, you cut the aorta, you cut the PA, and you take the heart totally out. You ended up and you cut the left atrium, at the edges of the this is the left atrial appendage. This is the mitral valve. So you cut the left atrium all the way as a circumferential cut, as you can see here, and then you resect the mitral valve. Then you shape a big bovine pericardium. You make a circular hole, and then you start putting your blood stitches into the mitral valve annulus through the patch, through the valve. Then when you go to the tumor in the back of the left atrium, this is how it looks after you finish your reconstruction of the mitral valve and mitral valve annulus. Then this is the tumor in the back of the left atrium. So you resect this area. This we talk out the most posterior structure of the pericardium. Below you, it's the esophagus and the spinal and the spinal bone, the spinal cord. Sometimes you can do this as a single patch, or sometimes even if the tumor is involving part of the pulmonary vein, then you have to reconstruct the pulmonary vein and do it like in separate ostium. Then you have to now, like as you do in transplant, you suture the reconstructed heart into the reconstructed pulmonary influence. After you finish this, you reconnected the same sequence as we do the transplant: the IVC, SVC, PA, and then aorta. This is how it looks at the end. It looks easy, but it's not easy. So angiosarcoma, as we said before, it's 80% on the right atrium. It's bulky tumor, can go into the RA, RV, TV, and right coronary artery. Usually it metastasizes to the lungs, liver, and brain. Surgery followed by chemotherapy. Very aggressive, poor prognosis. Without resection, 90% dies within 9 to 12 months, despite radiation or chemotherapy. Malignant fibrous histiocytoma. This is the most common soft tissue sarcomas in adults. Histologically, it's polygonal cells resembling histocytes, fibroblast or histoblasts. Left atrium. This is mimic a myxoma. That's why it's polygonal cells. If you remember, when we talk about myxoma, it's also polygonal cells. Usually, nomads at the diagnosis, and adequate surgical resection can be achieved. And I did actually one case like this before. Rhabdomyosarcoma do not evolve from rhabdomyomas. 60% develop from either ventricles. Invades the cardiac valves, tricuspid valve, and mitral valve. Microscopically, tumor cells demonstrate polymorphic nuclei, spidery, wispy streaming of eosinophilic cytoplasm. You don't need to remember this stuff. You just need to know that it does not develop from rhabdomyomas. It's very aggressive. Small tumor can be resected. Local invasion can be treated with chemo radio. There is other tumors such as myosarcomas, liposarcomas, osteosarcomas, chondromyosarcomas, blastocytomas, carcinosarcomas, and lymphoma. Lymphoma is also that can happen in the cardiac tissues and can be treated with radio and chemotherapy. Another important topic, it's pulmonary sarcoma. So pulmonary sarcoma can be staged according to its origin or where it does originate from. If it's only involving the main pulmonary artery, does not go to one side, then we call it stage 1. If it's involving one lungs plus the pulmonary artery, this is called stage 2. If it's involving both lungs, we call it stage 3. If it has any extra thoracic spread, this is called stage 4. How we diagnose this? Usually you see PA filling defect on the contrast and has CT scan. We get a gadolinium enhanced MRI. If tumor is enhanced, if the patient is stable, he goes through chemotherapy with adrenomycin and ifosfamide for 2 cycles, and then he'll go for radical resection. If the patient is unstable, we cannot give him chemo, so he has to go for radical resection. So the most common presentation presented with short breath and RV failure. Sometimes it can present like a PE, and you can treat it, you can actually, if this is a chronic PE, so I'm gonna go and do what you call thromboendarterectomy, and you get surprised this is a tumor. It originates from the base of the pulmonary artery just after the pulmonary vein, and histologically it comes from the mesenchymal cells, what you call the pulpus cordis. It grows distally in the artery and can involve lungs. The only way to increase survival is a surgical resection. You need to get a cardiopulmonary bypass by cable. You have sometimes to cut the aorta and SVC to access the right PA. Sometimes you have to do it under deep hypothermic circulatory arrest. Sometimes you ended up with doing an eminectomy to resect the whole tumor. How you follow these patients? For the first two years, you have to do a CT scan every 3 months, 3 to 5 years every 6 months, 5 to 10 years yearly after 10 if the symptoms recur. Usually, if any scan is positive, you get contrast-enhanced CT. If the CT showed there's a filling defect, you go for gadolinium MRI, and then if the tumor enhanced, you go for radical resection. Metastasized cardiac tumor, the most common you need to know: leukemia, melanoma, lung cancer, sarcoma, and breast. Either they're coming from hematogenous mets. This comes from the arteries, melanoma, bronchogenic tumor, and sarcomas, or come from the lymphatics, which is like lung, breast, esophagus, thymic. Or sometimes they can be local spread from adjacent thoracic tumors. Metastasis, most common presentation is pericardial fusion and tamponade. Can present with arrhythmia and congestive heart failure. Usually, the surgery just to relieve the symptoms. You do subxiphoid window and drain. And this is how the cardiac mets looks like in an autopsy. Sometimes renal tumor can get involved in the IVC and go to the heart. This is the most common called renal cell tumor. 10% can involve the IVC, and 40% from this 10% can reach to the right atrium. Sometimes you have to do sternotomy with deep hypothermic secretory arrest to resect the tumors, and the 5-year survival is 75%. Okay. Do you guys want to move forward or take a little break?
No problem, as you like, Dr. Mohammed.
I prefer to finish this and then we go for a break for 5 minutes and we'll finish the arrhythmia after, okay?
Okay.
I'm sorry, but the topic is the 3 big topics.
Thank you very much.
Okay. Hypertrophic obstructive cardiomyopathy. We're changing the gear from pericardial tumor, hypertrophic obstructive cardiomyopathy. Hypertrophic cardiomyopathy is a genetic myocardial disorder which characterized by the left and right ventricular hypertrophy that is usually, but not always, asymmetric and associated with microscopic evidence of the fibrosis of the myocardium. It's happened in 0.2% of the population. There was previously named as functional aortic stenosis, idiopathic hypertrophic subaortic stenosis, or hypertrophic obstructive cardiomyopathy, or HOCM. It's transmitted through autosomal dominant. Mutation can happen in beta-myosin heavy chain genes, cardiac troponin T genes, and alpha tropomyosin genes. I don't think you need to remember this, but this is for your knowledge. So as you can see here, 60% happens due to a sarcomeric protein gene mutation in 40 to 60%. 25 to 30% is unknown, and 5 to 10% this is due to the other genetic or non-genetic causes. So what you need to know that 60% of adolescents and adults with hypertrophic cardiomyopathy, it's a dominant trait caused by mutation in cardiac cyclomeres. This is an important. 5 to 10% of adult cases are caused by other genetic disorders, including inherited metabolic and neuromuscular disorders. Neuromuscular disorders such as Friedreich ataxia and other inherited disorders. HOCM involve the intraventricular septums and left ventricle, and it's variable in its location and severity. Ventricular septum in classical HOCM hypertrophied is maximum at the cephalad portion of the ventricular septums. Point of maximal thickening lies just apical, or what you call it coded to the free edge of the anterior mitral leaflet in its open position. Tapers off gradually toward the left ventricular aortic junction and toward the apex. It's like a bulge, and then it tapers off in both ways. Mid-ventricular hypertrophy. This is the ventricular septum hypertrophy at the site below the anterior mitral leaflet, adjacent to the papillary muscles. Usually, this kind of patient, they present with no SAM and they have no mitral regurgitation. Dynamic morphology and the septum and mitral valve. This is very important. When septal hypertrophy is classic, obstruction can happen in the side of the left ventricular outflow tract between the hypertrophied ventricular septums and anterior mitral leaflet, and this is what you call it systolic anterior motion, or SAM. In systole, the posterior mitral leaflet close against the body of elongated anterior mitral leaflet. So you have to imagine that the anterior mitral leaflet it's very elongated and will flip into the LVOT. So usually the what you call it the Sorry, guys. Give me a second, please, okay? Happen between anterior and posterior, just at the edge of the leaflet. But because of this septal hypertrophy, the anterior mater leaflet is pushed a little bit. So the posterior mater leaflet will touch to the anterior mater leaflet at the middle or at the body of the mater leaflet, and the edge of the mater leaflet will flip over to the left ventricle. I'll show you in the next slides. So SAM in HOCM, it's multifactorial, because this is what you need to know. Because if they ask you, usually they will ask you about the classical HOCM, which is associated with systolic anterior motion. It's multifactorial. Secondary, as I said, to the forward or anterior displacement of elongated mitral valve. This is what I say. Because of the septum hypertrophy, the anterior mitral leaflet is displaced anteriorly and relative to the septum during the systole. Okay, what happened? Because of the high velocity secondary to the septal hypertrophy, this also will produce a Venturi effect, which will also suck the mitral valve down, and also higher pressure below the left anterior leaflet force it further into the outflow tract. So this is the three important mechanisms that you need to understand. That the anterior mitral leaflet is placed anteriorly. There is a Venturi effect that's going to pull the anterior mitral leaflet more, and there is a higher pressure at below the anterior leaflet, which will force it against the LVOT. This is how we can. This is how. Okay, so in onset of the systole, you can see here that the anterior, both the posterior leaflet and mitral leaflet, it's at the coaptation zone. However, at early systole, the anterior mitral leaflet is pushed toward the LVOT, and finally will totally obstruct the LVOT. And as you can see here, it flips this way. As you can see here, this is the anterior mitral leaflet, this is the posterior mitral leaflet, and this is the thickened intraparticular septum. So usually, what I mean that when in normal heart, this will be open, right? So the anterior and posterior leaflet, they will co-opt at this point here. The anterior mitral leaflet will not flip into the LVOT. So because of the anterior displacement of the mitral valve, you see how this, because of the pushed septum, the mitral valve is anteriorly displaced. So this will cause that the mitral valve will not close in good position to the posterior mitral leaflet, plus the Venturi effect here, plus the pressure in the anterior mitral leaflet here, because the ventricle try to push the blood here. So it will be high pressure here. This in further will push the mitral leaflet toward the septum. Left atrium, it's often dilated because of decreased compliance of the LV and because of the mitral regurgitation. Mitral valve, intrinsic mitral regurgitation occur independently of SAM in about 20% of the patients. Right ventricle hypertrophied ventricular septum project into the right ventricle outflow tract. Sometimes you can see RVT gradient. This hypertrophy may cause important RVH secondary to pulmonary hypertension from long-standing left side heart failure. Coronary artery, usually larger than the normal. Some people, they have LAD bridging. LAD may become totally occluded during systole, and irregularly, which you call sawtooth appearance. Septal perforator sometimes can be obliterated, severely narrowing during systole. Subaortic or mid-ventricular obstruction may be latent or provoked, lapile, or persistence. In contrast, in non-obstructive HOCM, there may be no symptoms or signs, particularly in milder form. But for the next slides, we focus mainly on obstructive HOCM. Okay. So, what are the clinical features and diagnosis criteria for HOCM? Usually, patients presenting with palpitation. Most of these people, they will have atrial fibrillation. Usually, it's paroxysmal, but it will become permanent in 10% of the patients. Patient can have BVCs. Patient also can have a VT or subventricular tachycardia, and this can result in sudden cardiac death. In late stage, heart failure can present, and the patient can present it to you with BND, orthopnea, and pulmonary edema. The signs of, there is 3 cardinal signs of HOCM. I want you to remember these signs, guys, for the exam. There will be a late onset of systolic ejection murmur at the left sternal edge. Will be bifid arterial pulse unpalpable left atrial contraction, or what you call it, and this is what you called. Why patient will have a bifid arterial pulse? There will be narrowing of the LVOT, which creates more negative pressure due to the Venturi effect, which sucks the anterior mitral leaflet. This creates transient occlusion of the LVOT, and this causes a mid-systolic depth in the aortic waveform. Murmur, it's a mid-systolic murmur proportional in the intensity of the degree of the obstruction between the left sternal edge and the apex of the heart. It radiates to the base. The murmur increase intensity when the patient will do a Valsalva, because this will increase the degree of the obstruction. How we diagnose HOCM? In adult, HOCM is defined by a wall thickness more than 15 millimeter in one or more LV myocardial segment, as measured by any imaging technique. Electrocardiography or EKG, we can see LV strain pattern. Occasionally, complete right or left bundle branch block are often left anterior hemiblock. You can see sometimes giant T waves in V4 to V6 are typical and isolated apical hypertrophy. Echo, this is very important, is defined as an instantaneous peak pressure gradient more than 30 millimeter mercury at the rest or during physiological provocation such as Valsalva maneuver or standing and exercise. A gradient more than 50 millimeter mercury is usually considered to be a threshold which LVOT become hemodynamically important. So you have to remember a gradient of LVOT more than 50, it's hemodynamically important. Single most relevant parameter is the maximum LV wall thickness at any level. If a segment is not visualized adequately, LV ossification using ultrasound contrast agents and cardiac MRI can be considered. Okay, so this is a very important. How we do what you call a stepwise approach to defining obstructive physiology. So if the patient have a resting gradient more than 50, there's no brainer here. Then this is an obstructive physiology. If the patient does not have resting gradient, then you do Valsalva. If the Valsalva is done, then the gradient goes up to 50. If it's yes, this is obstructive physiology. If not, then you give him amyl nitrate because you want to dilate him, and you see if it's provoked. If it's provoked more than 50, it's obstructive. If not, and it's still there is suggestive symptoms, then you have to do what you call stress gradient. You put the patient in treadmill and stress him. If you have a gradient more than 50, then this is obstructive physiology. If not, then you take him to the cath lab and you do what you call cath gradients. As you can see here, this is intraventricular septum. You can see here the thickness, and you can see it's very narrow LVOT. What are associated abnormalities of the mitral valve and left ventricular outflow tract? 1/3 of the patient have resting SAM of a mitral leaflet, while another third have a latent obstruction only during maneuver that change loading condition of the LV contractility. So SAM will lead to MR. MR, it's mid to late systolic and infralateral oriented. Why it's infralateral oriented? Because it's anterior leaflet related. So they will have like inferior directed or posterior directed jet. Central or anterior directed, if it's central or anterior directed jet, then you have to think about maybe this is, if not posterior directed jet, then there might be a suspicious, this is not only HOCM, and there might be a problem like primary problem of the mitral valve. So what is the protocol for assessment and treatment for left ventricular outflow obstruct and HOCM? So if the patient have a maximum gradient more than 50, we'll go to the next slide. If the patient have a gradient less than 50, it depends if the patient is symptomatic or asymptomatic. If the patient is asymptomatic, you don't need to do anything. You just follow him with echocardiography in an ear. But if the patient is symptomatic, then you exercise him. If the exercise showed that the patient have more than 50, then he goes to the same pathway. If the exercise showed that he's provoked still less than 50, then you do a medical therapy. So cardiac MRI imaging is superior to echocardiography or in detecting LV apical and anterolateral hypertrophy, aneurysm, and thrombus. So we're missing a slide here. Okay. Anyway, TTE in HOCM. So what are the class 1 to do TTE in HOCM? Measurement of the, you can guys go through the guidelines, okay? Just gonna skim it quickly. Measurement of the maximum diastolic wall thickness using to do short axis view in all LV segment from base to the apex. Initial evaluation by Doppler at rest during Valsalva maneuvers in the sitting and in the semi-supine position and standing if no gradient provoked. Evaluation of the LV diastolic function. Symptomatic patient with resting or provoked peak instantaneous LV outflow tract less than 50. Then you have to do what you call exercise Doppler echocardiography. 2B, if the patient is asymptomatic with a provoked potential less than 50, then you do an exercise. 2A, if the patient have intravenous contrast echocardiography. So TEE, a perioperative TEE is recommended in patient undergoing septal myectomy to confirm the mechanism of the LVOT and to guide the surgical strategy to assess post-surgical complication and detect the LV outflow obstruction. Transesophageal echo should be considered in patients with LVOT if the mechanism is unclear. So class 1, if you're planning to do myectomy, you should do TEE. If you're not sure about the mechanism, then you go for a TEE. This is class 2A. You can use TEE with intracoronary contrast injection of the candidate with septal perforator arteries. And if you're planning to do a septal alcohol ablation, sometimes transthoracic is insufficient proper visualization of the echo contrast with the myocardium. Cardiac MRI, you can go through this. It's recommended studies to perform and interpreted by an expert team. In the absence of the contraindication, cardiac MRI is recommended in patients with suspected HOCM who have inadequate echocardiography window in order to confirm the diagnosis. So echocardiography, it's the gold standard, but if the echocardiography is not enough, it's class 1 to do a cardiac MR. And cardiac MR should be read by an expert team. In the absence of the contraindication, the cardiac MR should be considered in patients with fulfilling diagnosis criteria to assess the cardiac anatomy of ventricular function. So even if the patient does not have adequate echo, you could still get an MRI as class 2A. Cardiac MRI imaging should be considered in patients with suspected apical hypertrophy because, as we said, remember in the previous slide, the cardiac MR has a better visualization for the apical. CT, there is no class 1 indication for CT, but bone scintigraphy should be considered, or nuclear imaging in patients with symptoms and signs of non-invasive test consistent with the amyloidosis, because sometimes you can mix a HOCM with the amyloidosis, so you can get a nuclear imaging study. Cardiac CT scan should be considered in patients who have inadequate echocardiographic imaging and contraindication to MRI. So your first is echo, then MRI. But if the MRI is contraindicated, then you go for a CT scan. Cath, when I do cath, if it's the inconclusive echo or an obstruction, how I increase the obstruction? Increased by the increased LV contractility. That's why when we give an epinephrine, we make the ventricle more dynamic, then this will increase the obstruction. Or when I decrease the preload or afterload, okay? So when I give the patient a nitro, then he will drop his preload, and then he will become more obstructive. So how I increase the big gradient between the LV and aorta, and this will decrease the aortic pressure and increase the LV ejection time. So this is a very important, okay? So you see here, okay? You see here at rest, okay? So this is the patient at rest. You can see here, this is what you call the LV pressure, and this is the aortic pressure. There is no much, the LV pressure is higher than the aortic. There is a gradient. You can see here, 120 like to 150. There is a 30, okay. But when the patient develop a Valsalva, what happened? Your LV pressure increased. However, your aortic pressure keep dropping because of the obstruction of what? Of sound. And this is very important, okay? You can see here at the end of Valsalva, your LV pressure exceed 200, and your aortic pressure, it's almost 80. So this is like, this is with Valsalva, this is with the Valsalva, and the patient have a BVC. This is make it even more worse. This is in the cath. You can see here. This is this is the LV and this is the aortic pressure. When the patient get the BVCs, so you see that the aortic pressure, the LV pressure goes up and aortic pressure goes down. So it can present at any age. Obstruction present only in 20%. Clinical course is often stable over long periods. Sudden onset of heart failure is a frequent, but it's precipitated by atrial fibrillation. These people, they have a diastolic dysfunction. So you do not tolerate atrial fibrillation, because that when the patient goes in atrial fibrillation, they lose their atrial kick and they can go into a heart failure very fast. So what are the risk factors for sudden cardiac death? This is another important question you might be asked in the exam in HOCM patients. If you have a basal resting gradient more than 30, young age, patient present with syncope, if there is a family history of malignancy, myocardial ischemia, or the patient has sustained ventricular tachycardia, or family history of sudden cardiac death. So general measures. So management, again, in the guidelines, 2A, avoid arterial and venous dilatation. We know that because if you drop the preload or afterload, you will increase the obstruction. So you should avoid nitrate, phosphodiesterase inhibitors, resmelarenone, in patient with resting provoked LVOT. You have the restoration of sinus rhythm, because I said these guys, they have the diastolic dysfunction and they don't cope very well with atrial fibrillation. And digoxin is not recommended as a class 3. So medical treatment, we do a non-vasodilator beta blocker, such as propranolol, metoprolol, atenolol, which is, we do it as tolerated dose. This is the first therapy to improve the symptoms. Then if the patient is ineffective, you go for verapamil. If the patient is less than ineffective, you go to disopyramide. Class 2A, it's diltiazem. Class 2B, low-dose dope thiazide diuretics. You have to keep in mind when you use disopyramide, you have to watch for the QTC, because sometimes the QTC can get prolongated and the patient can develop arrhythmias. So if you compare beta blocker with calcium channel blocker and disopyramide, you can see here that the beta blocker, they have the decreased exercise gradient. All of them decrease exercise gradient. However, the calcium channel blocker improve the diastolic dysfunction, and the desmoprolide will decrease also the resting gradient. This is the initial dose, this is the maximum dose, and this is the side effect. So as you know, the beta blocker side effect is hypotension, fatigue, bronchospasm, calcium channel blocker, bradycardia, hypotension, constipation. This is very important question. It can give you anticholinergic effect and can increase the QT interval. You have to watch the QT. Septal reduction therapy, class 1, to be performed in experienced operators to improve symptoms with resting maximum provoked LVOT grading more than 50. If the patient presented with New York calculation class 3 and 4 despite medical therapy. Septal myomectomy rather than septal alcohol ablation undergoing other cardiac surgery. So if the patient is presented for another cardiac surgery, let's say the patient have coronary artery disease on top of HOCM, then you should not do septal alcohol ablation. Then you take them for surgery, you do septal myomectomy and CABG. Class 2A, recurrence exertional syncope caused by resting or maximum provoked gradient more than or equal 50 despite optimal medical therapy. Symptomatic with moderate to severe MR not caused by SAM. 2B, moderate to severe MR following isolated myomectomy, or maximum septal thickness 16 at the point of the mitral leaflet septal contract. So surgery versus alcohol ablation. Septal ablation may be less effective in patients with extensive septal scarring on cardiac MR, and in patients with very severe hypertrophy. That means very thick. If the patient is very thick, septal alcohol ablation, or the patient have extensive scarring, usually surgery will do better than alcohol septal ablation. In general, the risk of ventricular septal defect following septal alcohol ablation and septal myomectomy is higher in patients with mild hypertrophy. So if the thickness of the ventricle of the septum is less than 16 millimeter, here there is always a risk of having complication following each procedure. No randomized trial compared surgery and septal alcohol ablation, but several meta-analyses have shown that both procedure improve functional status with similar procedure mortality. Septal alcohol ablation is associated with higher risk of AV block, recurrent permanent pacemaker implantation. However, myomectomy patient will have a left bundle branch block. So, comparative feature of septal reduction therapies. We know one of the treatment is dual chamber pacing, or septal myomectomy, or septal alcohol ablation. You can see the mortality. It's comparable between these two. The resting gradient is better with surgery. Effectiveness is better with surgery than with septal alcohol ablation. However, it's like almost close to each other. We have prolonged follow-up with surgery, less follow-up with septal alcohol ablation. The complication with septal myomectomy can go into complete heart block, VSD, AR, or this can go VSD, complete heart block, and they can end up with a large myocardial infarction. Updated meta-analysis on septal alcohol ablation versus myomectomy, they found no significant difference in terms of the post-interventional functional status as well as improvement in neurocastration class. So, okay, let's make it. I'm sorry. This is the most fun part. Can anybody explain how we do septal myomectomy?
So initially, first of all, we'll go median sternotomy with the patient, and cannulation. It's depend on my planning if I'm intervening on mitral or not. But if it is only septal myectomy, so central cannulation and right atrium cannulation, then I will open the aortotomy, exactly like the AVR, going towards a non-coronary cusp. Then I will. The most important things is I will retract. I will ask my assistant to retract the right coronary leaflets gently. Then I need to assess the thickness of the septum. After that, I need with my knife, with a gentle, very cautious resection of the a large septum, keeping in my mind the preoperative measurements and how much I need to take. And it's better to take it slowly, better than end up with the VSD.
Okay, so what's your landmark of resection? From where to where?
Beneath the landmark resection, if it is in the LVOT, so I will just beneath the valve until I reach the mid septum.
Okay, so let me tell you something.
Midpoint from right coronary cusp to the area, the commissure between right and left.
So guys, from the nadir of right,
yes,
okay, to the nadir of left. This is your landmark, okay?
Okay.
And you go
till you reach to the anterior papillary muscle, base of the anterior papillary muscle.
You go all the way down to the base of the papillary muscles. This is very important. If I'm examining you in the exam, you say if there is no mitral regurgitation. So when you start prescribing any surgery, you have to keep in mind, what's my approach? I'm doing sternotomy. What's my cannulation strategy? How I'm going to protect the heart? What is my cardioplegia strategy? And how I'm going to venting the heart? Venting, protection, cannulation will approach. Okay. Then surgically, how I'm gonna open the aorta. I do lazy S shape as I do aortic valve. Retract the aorta. Then I use a special retractor to retract the right cusp. Then I will look into the septum. Identify the septum from the nadir to the nadir. Some people will take a stitch into the muscle itself to retract the muscle so you can cut. You say I will cut from the nadir of the right to the nadir of the left, all the way down to I make parallel lines to the base of the papillary muscles. بعدين what do? You assess the thickness. صح? This has to be determined pre-operatively. Let's say your thickness is 25. you want to make the thickness as like 25 millimeter. You want to make it as 10 millimeter. So you have to cut up to 15 millimeter. Okay.
Yes.
So this is as you can see the two parallel incision made and the septum, then the nadir of the right coronary and leftward. Okay, as you can see here. And then you cut the muscle down. Okay. And this is
Yes,
how
clear.
this is how we say it to the base of the anterior papillary muscle. This is very important. Okay.
It's showing from the nadir of the right to the commissure here.
Yes, sometimes it depends, you know. But I would say if you have to identify both nadir, okay, and if the septum, so because sometimes the septum can go all the way to the nadir of the left, okay.
Mm-hmm.
Because where is the mitral valve attached?
The mitral valve between the left and none.
Left and none. So the rest after the nadir of the left, this is all the interventricular septum. So that's why you have to be careful. Yes, you sometimes, if you cannot see, you can go up to the commissure, but you do from the nadir to nadir. Okay.
Okay.
The key principles is to obtain adequate relief of the LV tube obstruction is understanding that the depth of the septal excision is less important than the length of the resected portion. Okay?
So the depth
Do you understand this statement?
So the length is more important than the depth.
You have to go all the way down to the base, okay?
Base of the papillary muscles, okay.
Yeah. So mitral regurgitation in patient hypertrophic obstructive cardiomyopathy, retrospective review. You can see here overall survival comparing with age and gender. This is when you have myomectomy with mitral valve. They will have compare survival with general population. Mitral valve repair, they do better than the mitral valve replacement. So most patients with HOCM, mitral regurgitation related to systolic anterior motion, is relieved through adequate myomectomy. However, concomitant mitral valve is rarely necessary. However, if you need to repair, is preferred over replacement. Mitral valve repair is feasible in 50-60% of these patients using conventional reparative technique. Annuloplasty ring should be avoided. However, why we avoid the rings? Because rings can decrease the anteroposterior diameter and can push the anterior leaflet anteriorly, and this will actually cause SAM. But to prevent this, you either use flexible or rigid band only in the posterior leaflet, like C-shaped bands. Okay. Time-related survival. The largest surgical series, 5-year survival, has range between 84 to 96%, and 10 years, 71 to 88%. Wu and colleague, this is from California, in Stanford, they reported similar 10 and 20 years survival. Survival is higher in patients undergoing isolated myomectomy. What are the mode of death after discharge from hospital? Cardiac failure, sudden cardiac death, ventricular arrhythmias, and stroke. Risk factor for premature death: older age at operation risk factor, early and late death, female gender, preoperative syncope, increased neurocalcification, coronary artery disease, preoperative atrial fibrillation, concomitant procedure, develop heart block and pre-existent outflow tract gradient. Conduction disturbances, complete heart block can happen up to 10%. Complete left bundle branch develop approximately 50% postoperatively. Iatrogenic defect, this is rarely, it's happened less than 1%. McIntosh and colleagues believe that it's likely to happen if the patient have septum less than 18 millimeter. AR sometimes can develop, especially if you have small aortic annulus and if you have a low mitral septal contact lesion, probably due to increased operative difficulty. You increase the retraction in the valve, which injure the aortic valve cusp, and loss of support for the right coronary cusp as a result of the excision of the septal muscle bent. So you have to keep in mind sometimes after you finish your septal mammectomy, the patient will have AR, either because you retract the valve hardly and you cause injury to the valve, or because the right cusp lost its support. What are the solutions? Avoid excessive resection in the first few millimeters of the ventricular muscle, bend the RCC, may prevent the cusp prolapse and aortic regurgitation. Alternative therapy, as we said, it's percutaneous transluminal septal myocardial ablation, dual chamber pacing. Dual chamber pacing will decrease the subaortic pressure gradient and relieve some associated symptoms. The mechanism, it will decrease the septal motion, which increase the LV outflow tract areas and reduce the SAM of the anterior mitral leaflet. DDD pacing may be a particular value in elderly and other patients who are not candidate for mammectomy or septal ablation. So if the patient is not candidate, you entertain the idea of having a dual chamber pacemaker. This is the guidelines for that. Sudden cardiac death, no randomized trial or statistically validated prospective prediction models can be used to guide ICD implantation in patients with HOCM. Recommendation based on the observational and retrospective cohort. If the patient have LVT obstruction, severity of the LVH, family history of sudden cardiac death, history of cardiac arrest, or unexplained syncope, this is all indication to go for ICD. ICD implantation, primary prevention recommended. You look for two Doppler echo and 24-hour Holter monitor. HOCM risk of sudden cardiac death in age, family history of sudden cardiac death, unexplained syncope, left ventricular outflow gradient, maximum left ventricular wall thickness, left atrial diameter, and non-sustained VT. This is, you go for risk. But if the patient have a history of cardiac arrest or sustained VT or hemodynamic compromise with life expectancy more than 1 year, you go for ICD implantation. Then you assess the risk. If it's low risk, intermediate risk, high risk. If it's patient have and high risk, then you do primary prevention ICD S2A, intermediate risk 2B. If the patient low risk, it's 2-3, you don't need to do ICD. You follow them up with ECG, TTE, 24 Holter every 6 to 9 months, 6 to 12 months. And symptoms, 2A, symptoms limited exercise testing, 2 to 3 years. Thank you. I know it's too much information, but we can share with you the slide. And you can guys read it.
الله يعطيك العافية يا رب.
شكرا.
طيب